Okay. So we'll get started. Good afternoon. Welcome to the Wednesday afternoon lecture series. I'm Roland Owens, the Principal Deputy Director of the NIH Office of Intramural Research. It is my pleasure to introduce today's WALS speaker, Dr. Electron Kebebew, who has made remarkable strides in his research on endocrine tumors and has had an outstanding career as a mentor and a role model to surgeon scientists and other translational researchers. But before I do, I have two very quick announcements. The first is the code for continuing medical education credits. The code is 66818. I'll repeat that, 66818. Also, for those watching remotely, you can submit questions to the speaker anytime during this lecture. Simply click the button that says Send Live Feedback, which is below the videocast window. Type in your message and we'll relay your question to the speaker at the end of the lecture. Okay, now to our guest of honor. Dr. Electron Kebebew earned his BS in chemical engineering at UCLA and his MD at UCSF. After completing a postdoctoral fellowship studying cancer biology and a general surgery residency, also at UCSF, he rose to the rank of associate professor. For those of you who are thinking he looks familiar, Dr. Kebebew spent several years at NCI-CCR, where he became the chief of the Endocrine Oncology branch. In 2018, he moved to Stanford, where he continues to be an ambassador for the NIH Intramural Research Program. He is currently the chief of the Division of General Surgery and the Harry A. Oberhelman Jr. and Mark L. Welton Professor at the Stanford University School of Medicine. Electron is an internationally recognized expert in endocrine oncology and surgery. He has performed more than 5,000 operations on the adrenal, parathyroid, and thyroid glands, and for neuroendocrine tumors of the gastrointestinal tract and pancreas. He has over 200 invited lectures and visiting professorships. Electron has authored or co-authored over 400 scientific articles, 40 book chapters, and edited or co-edited 4 textbooks. His scientific contributions include the use of molecular markers in thyroid nodules to refine diagnosis and prognostication and the identification of novel targets for endocrine cancer therapy. His numerous awards, honors, and community service include a stint as the editor-in-chief of Thyroid, service on numerous NIH review panels, and the Van Meter Award from the American Thyroid Association for outstanding research contributions. The title of his lecture today is The Joy and Impact of Surgical Research. Please welcome Dr. Electron Kebebew.
Thank you very much for that kind introduction. It's wonderful to be back here at the Bethesda campus. Never thought I'd give a WALS lecture. I guess that means I'm getting older. But really, thank you for the privilege of giving the lecture. My lecture title is vague on purpose. It gives me a license to talk about anything, right? The joy and impact of surgical research. Since my days of being in the intramural program, nothing has changed. I'm still a civil servant and have no conflicts to declare. You're probably thinking, what is surgical research? And this is an article by Francis Moore in the Journal of Surgical Research back in 1973, where he said the research in human biology that will benefit surgical care. And he covered 3 areas: discovery, development, and delivery. Of course, in the modern day, you got to ask ChatGPT. That answer was way too long for me. In my mind, surgical research is really research done by surgeons that will impact public health and patient outcome. So a very broad definition. precision medicine, we've made significant headways. Much of this, though, has looked at pharmacogenomics or precision oncology, but really none has been written about or investigated about precision surgery. And I'm going to try to share with you for the first half of my talk examples of precision surgery and how that's impacted the management of patients. And I'm an endocrine surgeon, and I think endocrine tumors are the prototypical example for this. So I'll share with you some of the work we did and others have done that's moved this forward, where we really could offer optimal care based on the genetics of the disease or advanced imaging. So for any CME credit, these are my two objectives: to share with you the advances and how this allows us to provide personalized surgical care. And then the second half will focus on, as a surgeon in my research, I focused in areas where I could do better because my patient's outcome or the patient's outcome is not great. So I'll share with you some work we've done and others are doing in trying to prolong the life of patients with rare cancers. So what is this about precision surgery? Well, there's been such significant advances. We were fortunate enough when I was here and then transitioned to Stanford to participate in the Cancer Genome Atlas that looked at thyroid cancer, pheochromocytoma, paragangliomas, and adrenal cancers. And then many of the endocrine tumors, anywhere from 15 to up to 50%, have an inherited background. So the advent of next-generation sequencing, having that information at the point of care, at the time of surgical consultation, is important considering what surgical managements the patient should have. The other area is advanced in imaging modalities, both for diagnosis, better staging to determine the extent of disease, and in some cases, they determine the prognosis of the disease. I'll share with you some example of works that we did and others have done as well in that domain. So to me, I think we're practiced in the day and age where we could be precise with the surgical intervention and accurate in our intervention. And layman's term, let the crime fit the punishment, because as surgeons, it's always important to remember nothing is without a price. Even the simplest procedure could have morbidity or mortality. The first example I'd like to share with you is medullary thyroid cancer. It accounts for 5% of all thyroid cancers. The susceptibility gene was discovered in 1993 by the group at WashU and Cambridge. It's the only example I know of an inherited cancer syndrome where there's a germline mutation in the oncogene. Fortunately, there's really hotspot exons where these codon mutations occur, and there's very exact genotype-phenotype where, depending upon the codon mutation, the patient could be at risk not only for medullary thyroid cancer, but the other components of the inherited syndrome, pheochromocytoma, hyperparathyroidism. Well, during this time, I was doing my residency and did a couple of prophylactic thyroidectomies in young kids with my mentor at that time and became my colleague, Orlo Clark, and the pathology came back, this normal thyroid. Well, should we have intervened in these patients? They had a germline ret oncogene mutation. Not only did we do a prophylactic thyroidectomy, we also did a prophylactic central neck node dissection. And I remember following this patient with a hypocalcemia and managing the hypocalcemia that resulted from the operation. Well, I wrote this up, and it was surprising to find in the literature that 8% of patients actually in this setting end up developing lymph node metastasis. We also looked at the cohort where we found those with inherited disease, largely due screening and early genetic detection and early diagnosis, had a much better overall survival. So the window to intervene is early, because usually once a patient has developed clinical disease, as you could see in the survival curve there, you rarely cure the patients. Right about this time, surgeons were looking at this and discover, depending upon the type of codon mutation, the age or earliest age of onset of medullary thyroid cancer. Fairly informative information telling us for specific types of codon mutations that for those in the tyrosine intracellular kinase domain, you should intervene within the year of birth because they could develop medullary thyroid cancer at a very young age. In most instances, could wait 5 to 6 years of age. So based on this information now, we actually risk stratify the type of codon mutation and when a preventative thyroidectomy should be performed, in addition to knowing which patients are at risk of developing other tumors as a component of this inherited syndrome. But now we know for clinically evident disease that the tumor size, anything to 1 centimeter, and elevated calcitonin will dictate whether we should do a prophylactic lymph node dissection in the setting. And then more recent data looking at the desmoplastic reaction in the tumor on frozen section, if it's negative, none of those patients in over 200 patients evaluated had lymph node metastasis. So we use this information to inform our surgical intervention and offering prophylactic lymph node dissection only when these factors are present. So to take you back to what I shared with you when I was a PGY2, these patients didn't need a sentinel neck lymph node dissection, and for their specific type of mutation, we probably could have waited until the age of 10. So now, as endocrine surgeons, we use the genetic information both for monitoring and then recommending when a prophylactic thyroidectomy should be performed. Another area is pheochromocytomas and paragangliomas. Many of you in medical school and maybe residency remember the rule of 10, 10% pediatric, 10% bilateral, 10% extra adrenal, 10% metastatic. And I have a line through that because we know those rates actually depend upon what type of germline mutation the patient has. If the patient has an SDHV mutation, well, it's a much, much higher risk of them having metastatic or malignant tumors. And this has informed us as far as fumarate hydrolase as well as the MAX mutation being at very high risk for metastatic disease. And then for neurofibromatosis type 1, the RET germline mutation and VHL having a very, very low risk for having malignant disease. Obviously, these patients require surgical intervention if they have a functional tumor or there's mass effect or it is invasive and they have other sites of metastasis. As I said and shared with you already, the age of onset, the tumor size, and then whether they'll have multiple tumors or malignant tumors is really driven by the genetic background. And the growing list there I have of susceptibility genes that have been discovered, not all of them have we characterized a clear clinical genotype-phenotype association for, but for most, there's fairly good data. So how do we use this information? It's important because when patients are at risk for bilateral pheochromocytomas, and they have a germline VHL or RET proto-oncogene mutation, that we want to avoid adrenal insufficiency. I'm sorry that, a surgeon always has to have a video clip, and I didn't check if my video clip was working beforehand, so I apologize. But in those individuals, you could do a cortical-sparing adrenalectomy. Oh, that's what I needed to do. The other area, in the interest of time, I'll continue to go. The other area is pheochromocytoma and paragangliomas, or neuroendocrine tumors in general, have so many targets for imaging. I just have a mock figure there. We have upregulation of GLUT transporters, somatostatin receptors 1 through 5, L-amino acid transporters, and you ask what is the best modality to appropriately localize their tumor. If it's a patient with cancer, appropriately stage their tumor. And the functional imaging isotopes take advantage of these cell surface receptors. And so this is some work that was done here when I was here, and one of the few places, that is the NIH Clinical Center, where you could do such a study of head-to-head comparison of imaging studies. And as you could see, you don't have to be a nuclear medicine physician or a radiologist. In this case, this is patients with pheochromocytoma and paraganglioma. You could detect sites of disease much more sensitively with dotatate, and then followed by FDG. And this is the case as well for head and neck paragangliomas, where the dotatate detection rate is much higher than FDG PET. So, case in point, 16-year-old woman we see with a left pelvic paraganglioma. You see that as a surgeon. You'll take the patient to the operating room, and that's all you're going to remove if you don't do functional imaging with either FDG PET or dotatate. And then, if you do it, though, you recognize the patient has contralateral pelvic paragangliomas that should be addressed at the time of the operation. So, which ones? I think anatomic imaging, we learned with functional imaging, helps us determine the extent of disease, in which cases you address the disease that you've detected in a single operation, or if they've got a malignant tumor, then the patient perhaps does not benefit from having an operation. This is just data. It's a little bit dated, but from 2009 to 2021 includes data from Stanford as well, and you could see if you routinely use functional imaging studies in 237 operations, 75 were open, 162, but many of the opens we ended up finding were metastatic disease, so 22% of the patients had additional sites of disease that needed to be addressed at the time of the operation, and not too skewed to a cohort of patients with primarily inherited disease. And similarly, 14% of the patients that had no family history ended up testing positive, and the examples of VHL. RET is less likely because most of those patients present with medullary thyroid cancer. We were able to offer those patients cortical-sparing adrenalectomy. Another area that advanced imaging has made a significant impact, this was actually a protocol Samira Sadowski wrote and opened herself as a clinical fellow, and now is a Lasker investigator here. It's the only type of study, again, you could do at the NIH Clinical Center. There are studies that were prospective out of Rotterdam, but none that had been done here in the U.S. And what she did was compare head-to-head, a scan that really belongs in the history textbook of medicine, Altria scan versus DOTA scan, in addition to the anatomic imaging. And I thought the results were quite surprising. You could see patients that did not have any evidence of disease on Altria scan was significantly higher. So these were patients that were symptomatic with carcinoid-type flushing that we were able to detect the disease on dotatate scanning. And then also in some cases where patients we thought had localized disease, potentially benefit from surgical intervention, found they had metastatic disease, so long-acting sandostatin was the treatment of benefit to them, but then also identifying patients that could benefit from surgical intervention. Why is this important? Her study was one of the data points that the FDA used to approve the NetSpot test, which is now commercially available. But because of this study, the new guidelines for management of neuroendocrine tumors recommended that scan that could be dotatate, dotatoc, dotanoc should be part of the initial evaluation to accurately determine the extent of disease. Well, when you do a study, you have new findings, you end up getting new problems to address. Some of that were in patients who had recurrent disease, fabulous, you could find it on the dotatate scan, but then you have to go back in there and resect, and you could see some of the sites of the disease. I just have an example there. It'll detect things that are 4 millimeter in size. So we ended up spending 6 hours trying to look for this disease, and then asked the question, well, why don't we give the isotope before the operation and use a gamma probe and see if we could better detect, or at least it's a bed of scar tissue, remove it, and then check the ex vivo count to confirm we got what we were there for. And did this in 44 patients. Preoperatively had 133 lesions. The top ex vivo tumor to background ratio, that's TBR, shows the tumor sites had much significantly higher activity using the gamma probe. And that we figured out the window for this was within 3 hours. Probably not as important here at the NIH Clinical Center, but we're at Stanford where I practice. Nothing is guaranteed of when you're going to get into the operating room unless you're the first case start. So that was important information for surgeons to have. And then the most important take-home message was in 13% of the lesions, they were not visible or palpable. But we didn't find this modality really useful for pancreatic tumors as well as liver tumors because of the high background activity. But this could only be used in open cases. The group from Milan, Italy, just recently published their experience, again using a DOTA isotope, in that case is a DOTA-TOC, and evaluated this in 20 patients. Their beta probe, as you could see there, you could use with minimally invasive surgery, and pretty much confirmed what we had found, that the tumor to background ratio in the target lesion was significantly higher, and that you could use this to detect lesion that you might not be able to see. Again, I think most important in cases of reoperative cases, and that using the cutoff they used for the tumor to background ratio was 1.35 centimeters, gives you a relatively good high accuracy rate. Now, I've just given you 3 examples of endocrine tumors where the genetic background of the disease and advanced imaging modalities really have made a significant impact in how we manage these patients. In the interest of time, it's not the only site. I think this applies for patients with primary hyperparathyroidism as well, and then probably could spend talking about the advances in the management of thyroid nodules, molecular testing, where significantly reduced the need to operate on benign thyroid nodules by evaluating the somatic mutations that are preferentially present in thyroid cancer, as well as dictating the extent of thyroidectomy that would be necessary. But I hope I've convinced you. I think, at least in endocrine surgery, we're able to practice precise surgery based on the genetic background of the disease and advanced imaging modalities. Next, I'm going to talk about work in progress. And for me, I've focused much of my career, the line of investigation, in areas that we could do better, be it in molecular diagnostic for thyroids. I'm not in the business of doing diagnostic thyroidectomies, and patients don't need it, so had some success in that area. The one area that at least I've not had success as an endocrine surgeon, is for the rare cancer types, and that's anaplastic thyroid cancer. Much of this is because most of the patients present with advanced disease. But interestingly, even if the patient has localized disease, I've never had a patient survive more than 2 years. Similarly, patients with adrenal cortical carcinoma also present with advanced disease. But even when they're localized, more than half of the patients after a complete negative margin resection end up having recurrent disease. So why study rare cancers? Well, It's pretty interesting because it accounts for about 27% of all cancer diagnosis, and same amount of mortality, 25%. So it's an important for there to be investigators that focus on this area, but also resources to study these cancers, because in many instances, and I'll share with you for adrenal cortical cancer, what works in colon cancer, what works in lung cancer is not going to work in adrenal cortical cancer, because the biology and the molecular features and what drives the initiation and progression of adrenal cortical cancer is markedly different. Why study rare cancers? When you look at the gains that have been made in the survival of solid adult cancers, where from 57 to 70%, we've nearly not seen the same gain for rare solid cancers. Another reason to focus on studying rare cancers. So what about adrenal cortical cancer? Well, there's been no new therapy approved by the FDA in 6 decades. As I shared with you, more than 2/3 of patients present with locally advanced or metastatic disease. And this is a randomized control trial, the FIRM-ACT trial, that defined what should be the first-line therapy. So mitotane is what's approved for adrenal cortical cancer. And they combined it with EDP, etoposide, doxorubicin, cisplatin, or streptozocin. And what won out was mitotane combined with EDP compared to mitotane and streptozocin. The partial response rate in the study was 23%. The complete response rate was 2%. And guess what? That was 2 patients, both of which had a partial response and then subsequently had surgical resection. So not in the true sense a complete response. And they allowed patients to cross over if they progressed on one regimen and found that the overall survival of the response rate was not significantly different. So we clearly need to do better in this venue. Well, as I shared with you, we've been fortunate to participate in the Cancer Genome Atlas study for adrenal cancer. And this was really important for us to understand what were the driver event, both epigenetic and genetic, as this was an integrated genomic analysis of adrenal cancers. The problem I thought with this and had when we were participating is we're looking at primary tumors. And we're not looking at recurrent or metastatic disease, which is really what kills patients. Leave it as it may, the main findings from this analysis was that there were 3 molecular subgroups, cluster of clusters, that were related to prognosis. We also understood the 4 major pathways involved in adrenal cortical carcinogenesis. That was the beta-catenin and Wnt, cell cycle regulatory genes, and as well as transcription factors and the protein kinase cyclic IMP pathway. Unfortunately, it's been difficult to target these pathways. In some cases, are not targetable. I think what was very informative in this analysis is the comparison to 33 different other cancer types that was under the auspices of the TCGA study, and in over 10,000 tumor samples, and that adrenal cortical carcinoma had a unique molecular profile unlike the rest of the solid cancers that it was compared to. Well, we had done studies, and then in the TCGA study, one of the targets that had come out was IL-13 receptor alpha-2. Its expression profile is reminiscent of a cancer testis antigen. Some have referred to it as a decoy receptor. Given this finding, at that time, Raj Puri is at the FDA and had a IL-13 pseudoexotoxin conjugated to IL-13, and Meenu Jain evaluated the expression of IL-13 receptor alpha-2 in adrenal cortical cancer and found 100% of the samples we had expressed moderate to strong levels, and then conducted in vitro studies, and you could see there in the bottom panel, the tumor spheroids are completely disrupted when they were treated with IL-13 Pseudomonas exotoxin, as well as conducting in vivo studies with intraperitoneal injection of the IL-13 PE with significant tumor regression there, as you could see, up to 3 weeks after receiving single dose or sequential doses. So we were super excited about this, and I'm sharing with you some of the studies we did here so the trainees, the fellows in the room could appreciate what kind of science you could do here. And we were able to translate this into a phase 1 trial where we gave systemic intravenous infusion of IL-13 Pseudomonas exotoxin in patients that had unresectable adrenal cortical carcinoma. No surprise, much like we in our biobank specimen, all of the patients had strong immunostaining for IL-13 receptor alpha-2. But when we gave it to the patients that were enrolled, first thing you notice is, and did pharmacokinetic studies, that the half-life of IL-13 PE was quite short. And when we did the dose escalation, went from 1 to 2 microgram per kilogram per patient. That was the maximum tolerated dose. 2 out of the 3 patients at that dose ended up developing acute renal failure. But probably the most important thing is 2 out of the 6 patients that participated already had a neutralizing antibody to IL-13. And then the other 4 patients that got infused then developed neutralizing antibodies. So although very, very promising in the preclinical studies, the results were negative. Well, in the era of CAR T cells, Anush Kalbasi is a colleague at Stanford, and they have generated a mutated CAR T cell that targets IL-13 receptor alpha-2 and are hoping will not target alpha-1 to avoid toxicity, and have a phase 1 trial now open at 3 institutions. This is supported through the California Stem Cell Agency, where Stanford, UCLA, and City of Hope are sites. And personal communications, he's not presented this or published this, but I was excited to share this with you, that first patient that they've treated has a dramatic response to this with no toxicity observed. So I still believe that IL-13 receptor alpha-2 is a phenomenal target for therapy for patients that have unresectable adrenal cortical carcinoma. Well, now I'm going to switch over to anaplastic thyroid cancer. I just got through telling you I have not cured a patient beyond 2 years who had anaplastic thyroid cancer that was resectable. And this is just NCI-SEER data that shows you even when patients have surgery, their overall survival is poor, and those without, essentially the mortality rate is 100% within a year and a half of them being diagnosed. It's interesting, although it only accounts for 1% of thyroid cancers, that is anaplastic thyroid cancer, as you could see, relative to its low incidence, it accounts for nearly 2/3 of all thyroid cancer mortality. So if I was funding thyroid cancer research, I'd be funding what's killing patients, because that's really what drives. The rest of those patients either have poorly differentiated thyroid cancer and rarely well-differentiated metastatic thyroid cancer. So why is that? Well, all anaplastics are staged as stage 4, and as you could see, even localized tumors are stage 4A, and then 4B being lymph node involvement or local invasion, and then 4C being metastatic disease. And as I shared with you, only 10% of patients actually have localized disease where it's even resectable. Well, although there were no anaplastic thyroid cancer samples analyzed in the TCGA cohort, there have been really excellent studies in using high-throughput genome sequencing studies to analyze what the primary genetic drivers of anaplastic thyroid cancer are. And this is a nice study that actually compared it to poorly differentiated thyroid cancer here. And then patients who had a focus of anaplastic thyroid cancer, that's microscopic diagnosis, and then patients with widely invasive follicular thyroid cancer and metastatic thyroid cancer. Just want to point out a few important things. As usually there's a female predisposition for poorly differentiated, well-differentiated thyroid cancer. You don't see that in anaplastic. It's almost 50-50. As I've already shared with you, almost all of the patients have not survived. And then additional mutations, that is coexisting mutations, are actually quite common, more than one driver mutation being an anaplastic, which speaks to its origin from differentiated thyroid cancer. What was interesting is, even though it's uniformly lethal, those patients that had TERT promoter mutations had a worse survival time. And then when you look at whether it was a BRAF or RAS mutation, those are the patients that almost universally had 100% mortality. Additionally, beyond the morphology of the cancer, now we're able to atlas all of the mutations that are present. And in looking at this, 95% or more of the anaplastic thyroid cancer either have a driver mutation in the MAP kinase pathway or the PI3 kinase AKT mTOR pathway with a high mutation burden. So that gives us new treatment options, right, in the new world of discovering these driver mutations, having small molecules that could inhibit these activating mutations. And the two things I have in the red box there are things that have now been clinically approved for anaplastic thyroid cancer, combination MEK and BRAF inhibition, as well as checkpoint inhibitors. And I'm just going to share with you a study done by the MD Anderson group that really gives us the current state or state of the art of treatment for anaplastic thyroid cancer, where they went back and looked at these treatment modalities and whether patients had BRAF V600 mutation and whether targeted therapy was used and whether immunotherapy. And as you could see, when they look at the cohort in the more 2017 to 2019, where the patients had a BRAF mutation, got combined MEK and BRAF inhibition with PD-L1 inhibitors, that their survival was much better, right? But almost all of these patients develop resistance or treatment-related toxicity where they need to have dose reduction or treatment stoppage. So although the initial response is excellent, in some instances we consider this neoadjuvant therapy because they become surgical candidates, almost every patient after 2 years has recurrent disease or disease progression where that targeted therapy is not effective. Now I'm going to share with you some work we started here, actually, the 3 therapeutic strategies that we have used. One was to do high-throughput screening. Lisa Zhang remembers this. They've been at this for 10-plus years in collaboration with NCATS, where we say, well, the therapies are going to be driver mutation agnostic and screened over 3,000 compounds. And this was an attractive approach because many of these drugs were already approved for something or were in clinical trial where it could lead to easily efficient repurposing of the drug. And their mechanism of action in large part was known, as well as their toxicity profile. But as many of you know, monotherapy is not likely to work, especially in anaplastic thyroid cancer. So what we did next was take those active compounds and do a drug matrix screening of 28 drugs to identify which drugs might have a synergistic or additive effect across the anaplastic thyroid cancer cell lines that we had screened. Well, this led us to identify two synergistic compounds, natoxinide and orinophine. Natoxinide has been in use as an antiparasitic for the last 5 decades. It's an inhibitor of the pyruvate ferrotoxin oxyreductase enzyme. And then orinophine has been in use for rheumatoid arthritis as second-line treatment, and it inhibits the thyrodoxine reductase, both of which cause oxidative stress. And Chandra Yi looked at this and screened thyroid cancers both with BRAF, driver mutation, wild type. She found significant synergistic effect, as you could see in the clonogenic assays, with the combination treatment almost completely wiping out the colonies across really 4 different cell lines. And then similarly, using a patient-derived organoid, this is a patient, ATC1, who presented with a primary tumor and never received any systemic therapy, but went on to have a BRAF mutation and was given a combination MEK-BRAF inhibitor. And then ATC2 is a patient-derived xenograft or organoid that we developed from a patient that responded exceptionally well and only had residual lymph node disease that required resection. And you could see in both examples the organoids are significantly decreased or destroyed with combination natoxinide and orinophine treatment. Went on to do this in vivo orthotopic model, and then again you see in 2 different cell lines the combination treatment was significant. And what was interesting about this data is the tumor that formed a more aggressive disease actually responded better to the combination treatment than the cell line that formed less aggressive disease. Since both of these compounds are in use clinically, this would be easy to translate into a clinical trial. She went on to look at the mechanism of action. Initially, we'd done RNA-seq to look at the expression analysis and pathways that might be involved, but we ended up finding the drug mechanism of action that was described was really what was at play here, where orinophine ends up inhibiting both GPX4 levels as well as TRXR. That led to increased intracellular ROS levels, and then natoxinide inhibited late-stage autophagy, resulted in endoplasmic reticulum stress, which also increased the total ROS level. And that's why we observed synergistic anti-cancer activity when we used them in combination. So we hope to translate this into a clinical trial through the FDA. The second line of the 3 therapeutic strategies we've used is to look at what are the resistant to BRAF inhibition pathway that have been reported. And one of the mechanisms that's been reported, and this is not just to BRAF inhibition, to even immunotherapy resistance, is through the resistant cells have a mesenchymal state that's dependent on GPX4. And GPX4 has been reported to be a gatekeeper and suppressor of ferroptosis. And this is always a good thing to work and interact with smart people. At Stanford happened to be Scott Dixon, who described ferroptosis. And what's ferroptosis is an iron-dependent, non-apoptotic cell death pathway. So with the talent that was there, we thought this would be a good opportunity for us to pursue this line of investigation of whether targeting ferroptosis or inducing ferroptosis with BRAF inhibition could lead to more effective therapy. I just have there a cartoon of the two canonical pathways that are known for inducing ferroptosis, one through the XC system where there's a known inhibitor of this, Erastin, and then specific inhibitors of GPX4, RSL3, and FIN56. So we looked at doing this in combination with BRAF. And this is data there I have in the top panel across 4 cell lines. In the red box are the BRAF mutant anaplastic thyroid cancer cell line, as you'd expect. Dabrafenib, it's there abbreviated in DAB, significantly inhibits cell proliferation in those BRAF mutant cell line. And then targeting the XC system complex with Erastin actually induces significant cell death, but that death is actually different in that the mutant is more resistant than the wild type. And then when you target GPX4, either using RSL3 and then another compound ML162, you get pretty much significant cell death, and there's no difference based on the BRAF mutation status. The lower panel of figures here is using these two compounds. Since RSL3 had a great effect on inducing ferroptosis, we used that in combination with dabrafenib. Here is single agent dabrafenib here. Here's single agent RSL3 in blue, and then you see the combination. And again, across all 3 cell lines, you see a synergistic effect. And then this just plots the combination index of the drugs. Generally, combination index of less than 1 is synergistic. And then, as we'd expect with the BRAF wild type, you don't see that synergistic effect and should not. He also did this in the patient, both cell line and patient-derived organoids, and the combination treatment here totally disrupted the organoids, both the cell line and patient-derived. And then we did in vivo studies, again, the orthotopic model. In this case, we measured the tumor volume as well as it had a luciferase reporter, the cell line. And what you see here, that ferroptosis induction with, this is C18, which is a compound in development for clinical use with a much longer half-life than RSL3. And then IKE is also an Erastin analog that targets the XC complex to induce ferroptosis. When both were used in combination, that there was significant growth inhibition compared to single drug. And then similarly, when measuring the luminescence, the combination group had significant effect. Well, I already shared with you the reason we're interested in targeting ferroptosis is it's been implicated in mediating resistance. So he went ahead and looked at cell lines we maintained in up to 40 micromolar of dabrafenib, so highly resistant. And as you could see, when you add ferroptosis induction to it, these cell lines, this is P is for parental, and then this is the resistant cell line clone. And when you add RSL3 to inhibit GPX4, you get significant reduction while the Erastin was not effective. That makes sense because RSL3 directly targets GPX4. And then similarly in another cell line here with significant sensitization to BRAF inhibition when you add RSL3 inducing ferroptosis. So this has promise in the sense not only for primary treatment, but also if there is BRAF resistant, that inducing ferroptosis could lead to significant anti-cancer effect. When he looked at what the mechanism of action was, is we found that the intracellular accumulation on iron was high, and when you looked at importers of iron and exporter, that there was down regulation of ferroportin 1, that again led to enhanced Fenton reaction with generation of ROS. And then when measuring intracellular ROS or MDA consistent with the oxidative stress that resulted, that led to lipid peroxidation. And then when we looked at as the synergistic effect mediated principally to an enhanced ferroptosis and oxidative stress with lipid peroxidation, all of the associated antioxidant defense activation there was present with combination treatment as opposed to single agent. Lastly, the third area that we've been working on is, since I already shared with you, 95% of anaplastic have activation of both the MAP and PI3 kinase pathway. Is there something we can't target? Well, dual targeting of both of these pathways have been done. Why was PDPK1, 3-phosphonocetine-dependent protein kinase 1, so attractive to us? Well, it was downstream of where the activating mutation in the PI3 kinase occur, and it's responsible for activating AKT by phosphorylating it. So we thought this would be an attractive target. And then the second reason is there's really no studies in cancer where it's been targeted for therapy. The other reason we were interested in, I shared with you our high throughput drug screening study for anaplastic thyroid cancer. And when we looked at the active drugs from that screening in the cell lines, the top pathways, that is the enriched pathways, that is compounds that were really super active, were PI3 kinase pathway inhibitors. So for that reason, we thought this would be an attractive target to evaluate. We first evaluated it in cell lines, and the phosphorylated PDPK1 was quite high in all the cell lines that we analyzed, as well as the 2 patient-derived tumor samples that we had here. So for that reason, we used a small molecule inhibitor, BX795, to target inhibition of phosphorylation of PDPK1. And these are 2 cell lines that are BRAF mutant here, and then you could see that BX795 effectively inhibits the phosphorylation of PDK1. It's also referred to as PDK1 in both cell lines. What was interesting is when you have monotherapy or just BRAF inhibition, in many instances, you get feedback activation of the PI3 kinase pathway. So here in the second lane, as you could see, you have upregulation of phospho-AKT, and then when you do combination therapy, that upregulation is attenuated. And then similarly, when you inhibit the PI3 kinase pathway, the last column here and third column here, you get upregulation of phospho-MEK, upregulation of the MAP kinase pathway, which is attenuated with combination treatment. What was exciting is that we found that this combination of inhibiting PDPK1 phosphorylation with BRAF inhibition had synergistic anti-cancer activity looking at colony formation assays, as well as in vivo studies that he's run already that shows that this combination works effectively than just BRAF inhibition alone or PDPK1 phosphorylation alone. And he's teasing out the mechanism of action. It looks like it enhances apoptosis, principally through DNA damage, as well as causing, when we look at cell cycle arrest, G2M arrest. And all of the markers for apoptosis, this pointer is way off on its own, with combination treatment that's cleaved PARP, BCL2, as well as cleaved caspase-3 are increased. So this looks to be a promising approach to BRAF mutated anaplastic thyroid cancer that are resistant or maybe even as primary treatment. What's left for us is to identify the optimal PDPK1 inhibitor to use for in vivo studies that have a significantly long half-life, and those studies are being done by Dr. Paul, that we hope to use this then in combination with BRAF inhibitors. Well, I've given you a whirlwind of examples of clinical advances that have led to precision surgery, as well as work in progress. I hope I've convinced you that surgery is not barbarism anymore and that surgeon scientists have something to contribute. I'll just finish up with a summary that, based on a better understanding of the genetics of endocrine and neuroendocrine tumors, as well as advanced imaging modalities, we've been really able to impact the care and management of these patients to avoid futile interventions, as well as determining what's the appropriate surgical approach and extent of resection that I believe have resulted in better outcomes. And then I hope I've given you a few examples of work we've done, others are doing, that there are some promising avenues for the treatment of rare cancers, specifically adrenal cortical carcinoma and anaplastic thyroid cancer. And then lastly, I hope you believe surgeons have something to contribute in research. Thank you for the attention. These are all colleagues both at Stanford University and folks that I still collaborate with here at the NIH. Lisa Zhang, who did much of the high-throughput screening of the small molecule compounds with Dr. Zhang and Shen at NCATS, and then Mariam Boferkech, who still joins us for our research meetings every week and has tremendous smart things to offer our group. So thank you for the privilege of giving the WALS, and I'm happy to answer any questions you all might have.
Thank you. Please use the mics. Any questions you might have? Dr. Owens, do you have something here? You can give you the privilege of using this handheld.
Yes. I'm going to show my ignorance and ask, so what is dotatate detecting?
Yeah, sorry. So dotatate is a ligand for the somatostatin receptor. It's a third generation that has high affinity and specifically binds to somatostatin receptor 5 and 2, which are expressed highly in neuroendocrine tumors and pheochromocytoma ganglioma. It's also been effectively used for therapy. It's commercially known as Lutathera. So it's useful for both diagnosis, determining the extent of disease, and now, depending on the radioisotope it's bound to, could be used for therapy as well.
Please.
Thank you so much for a beautiful lecture and sharing with us great achievements. I have a question related to anaplastic thyroid cancer and dual MEK and PI3K-AKT inhibition. Looking back at MD Anderson group's experience of neoadjuvant application of BRAF-MEK inhibition, what's left in the neck is actually redifferentiated tumor, namely papillary thyroid cancer. So in your models, have you observed redifferentiation markers? Does it affect also expression of thyroglobulin, sodium iodine importer, TPO, PPR gamma? Have you observed this as a potential another promising avenue of mechanistic action of this?
Yeah, thank you for that very insightful question. The redifferentiating effect by inhibiting the MAP kinase pathway, PI3 kinase, has been observed in vitro as well as in animal models. We have not specifically gone into looking at that in the pathways that we've targeted and evaluated. Part of it is, my feeling is that therapy that we're evaluating should just work by itself. Although I think there is a redifferentiating effect, you're probably familiar with Jim Fagan's work and what resulted in a huge trial of you inhibit the MAP kinase pathway, the sodium iodine symporter expression, which is symporter for radioactive iodine, which is very effective for treating thyroid cancer. And based on his observation, and patients used that both in with RAS or BRAF mutated, published in New England Journal of Medicine, pretty robust response. But then we've gone on and found that in the large trial, there's really no significant difference. So I think that I have not looked at it because I think that whole area of investigation, you need to actually characterize where the NIS is. You need to characterize the retention of the iodine. And my research group is small. So we need to focus where initially the big bank is. So to answer your question, we haven't focused on it, but I think that's a very excellent question that also requires further investigation where that redifferentiating effect is actually useful for therapy.
Thank you so much.
I have a question online, similar to what I had asked you earlier today. What are your thoughts on the value of databases linking data from electronic health records and cancer registries to understand treatment outcomes in rare cancers?
Yes, I think that's extremely important. I think it's an important resource. With the targeted therapy coming online and the overall improved survival that's been reported by the MD Anderson group, we actually have gone back to the SEER data and found there is no, when you look at across the country, there's no significant improvement. There are beginning to be some, we happen to use the EPIC, electronic medical record.
Yeah.
And now there's a platform where multiple institutions are participating where it's primarily for research, but allows you to ask important questions for rare cancers and then also determine whether these treatments are actually available at most institutions. So, yeah, I think it's extremely useful. There's beginning to be platforms to be able to do that. But then again, I think you need a bioinformatician, a data scientist to really be able to access and pull that data.
Okay. Yeah, let me repeat the CME code. It's 66818. I was hoping to announce the reception to be delivered with surgical precision, but it hasn't arrived yet, which is a drag. But maybe if we take our time walking up, things will change. And Dr. Owens, do you have a final comment?
Thank you, everyone here and in cyber world for joining us. And hope we do this every Wednesday. So hope you can be here.